Pain in the anterior tibial tendon is a common condition, especially among active individuals, runners, or patients with postural or gait abnormalities. In many cases, this pain is accompanied by a decrease in anterior tibial activation, which can complicate function and make the symptoms chronic. However, not all activation deficits have the same origin. Some are the result of a deficit of central origin, while others are related to errors in movement execution. If you work with patients who have muscle activation deficits, understanding the true origin of the problem is key to guiding treatment. Thanks to electromyography with biofeedback, it is now possible to identify whether the deficit is of central or mechanical origin, allowing you to make more precise clinical decisions and retrain the muscle pattern in an objective and efficient way. Discover how mDurance electromyography can help you improve your patient's muscle activation from day one. I'll leave a link down below. In this post, you will learn how to differentiate between both types of deficits with real examples and apply tools such as surface electromyography and biofeedback to effectively retrain muscle function and movement. Step 1. Assess muscle activity with an analytical test. The first step is to assess whether there is an actual muscle deficit in the anterior tibialis. To do this, we use a simple test, which is a manually resisted dorsiflexion. Pay attention to the result. The right anterior tibialis activates the same as the left anterior tibialis. This indicates that there is no deficit of central origin, since the muscle is able to activate normally when isolated in a specific voluntary contraction. Step 2. Assess a functional movement under load. Next, we are going to analyze muscle activity during a more complex movement, a squat, which involves motor control, stability, and coordination. Pay attention to the result in this case. Here, the right anterior tibialis activates much less than the left anterior tibialis. Although in the analytical test, both muscles activated exactly the same, during the squat, the right tibialis activates much less, which suggests a dysfunction of mechanical origin, probably related to the motor pattern. So where is the real problem? Even though in the analytical assessment, the right anterior tibialis shows activation similar to the left during a functional exercise like the squat, activation on the right side was clearly lower. This difference is not due to a structural muscular deficit, but rather to an alteration in the way that muscle integrates within the loaded motor pattern. More specifically, the problem appeared when the foot was planted on the ground, acting as a fixed distal point. In this situation, which requires stabilization and control during load reception, the right anterior tibialis is unable to activate with the same intensity as the healthy side. This finding leads us to conclude that there is not a failure of the muscle itself, but rather an alteration in the neuromuscular integration of the anterior tibialis within the functional movement pattern. In other words, the muscle does not activate properly when the system needs its participation to stabilize the joint during the execution of the squat. To address this altered pattern, we use a key tool, biofeedback through electromyography, which allows the patient to visualize their activation in real time and adjust their performance. Let's look at an example of Reeducation with biofeedback using two different strategies. The first is to use biofeedback with a simple instruction. The patient is asked to simply raise the purple line corresponding to the right anterior tibialis on the graph. Take a look at the results. In this case, we were not able to increase muscle activation using only biofeedback and a verbal command. It was not enough to modify the motor pattern. The second strategy is to use biofeedback along with a detailed explanation. You will accompany the biofeedback with a more specific instruction. Try to place your whole foot down, including the heel, not just the midfoot, and aim to raise the purple line. In this case, look at the result. The patient is able to activate the right anterior tibialis more, correcting the execution of the squat and adjusting the motor pattern thanks to the visual information and your explanation. Comparing the electromyography graph, you can clearly see how the combined use of biofeedback and the detailed explanation leads to a significant improvement in muscle activation. The patient went from a dysfunctional pattern to a more efficient one, without needing to change muscle strength, just by correcting the way they move. Therefore, this case demonstrates a fundamental idea. Not every activation deficit is a muscular deficit. Sometimes the problem lies in the movement, not in the muscle. Using tools like electromyography with biofeedback allows you to identify whether the deficit is of central or mechanical origin, make more precise clinical decisions, and retrain muscle activation effectively and objectively. See you in the next post.